Okay, guys, welcome back. So now we'll get into some specifics on how an organ is allocated, right? And specifically looking at hearts. So overall, there is a thing called the donor allocation system. And there's two kind of key organizations that you need to be aware of. So there's the Organ Procurement and Transplant Network, or OPTN, which is operated under the U.S. Department of Health and Human Services, which divides the country into 11 regions, and there's even like kind of subdivisions within there, and that kind of monitors basically the availability of organs in patients who need transplantation. This is typically supervised and implemented by UNOS, not the card game or the pizza shop. But the United Network of Organ Sharing. It's a private organization that helps ensure equitable distribution of organs in a nonprofit NGO. So it is, the priority for organs overall, right, just in a general sense, is based on the severity of the illness of the patient, the geographical distance from a donor, right, and then their wait time, how long they've been on the waiting list, right? So in general, the matching systems considers the distance between a donor and a transplant hospital. So in general, the local candidates get organ offers before those listed at more distance hospitals. So if we know there's a patient at a hospital that needs an organ and there's someone at a hospital nearby, they'll try to match them before they get it to someone at a farther hospital. And the reason for that, and this is all monitored through computers and different algorithms and stuff, and other factors are included as well, but these are the primary factors. So the reason why the time or the distance kind of matters is because the organs don't last forever once they're harvested. So again, hearts, we're looking at urgency, distance from the donor hospital, like how far is the patient from the person who's going to be donating or harvesting, or the organ's going to be harvested from. Same thing with lung, survival benefit, medical urgency, waiting time, and distance from the hospital. This is all from OPTN and UNOS. It's important to bear in mind that an organ harvest from a heart and lung only lives for about 4 to 6 hours. Is that organ viable? So if it's not, not a viable organ, we can't use it. So the distance really does matter. So that's why things are broken down as geographical networks, and we try to have patients typically stay close to the facilities. If they're staying at home, maybe if they're have an LVAD, they're staying at home, or they're in even sometimes the same hospital potentially. We try to match them up. Say, hey, we've got this patient here with heart failure. They're waiting for a transplant. Oh, someone came in with a car crash, or an accident of some kind, and they're brain dead, and we're gonna they're an organ donor. We're gonna try to match this person to see if it's a match, because again, there's only 4 to 6 hours that these organs last, right? So, yeah. All right. So, in terms of heart transplant status, we'll get into this later on. For lungs, it's a different scoring system. But heart transplants, there's I think 6 statuses now. This has been updated in the fall of 2018. So status 1 is the highest priority, all the way down to status 6. Status 1 is anyone on VA ECMO who is non-dischargeable, right? So these are patients that are on these devices, so VA ECMO, or they're on some sort of mechanical circulatory support device, remember that MCSDs, that they're I don't say institutionalized, but they are in the hospital. They cannot go home. They are critically ill. They to the point where they're not able to leave the facility. So that's status 1. These are the highest priority patients. Status 2 would still be non-dischargeable, so they're in the hospital. They have a surgically implanted non-endovascular LVAD, or they're an IAPP or some other sort of percutaneous endovascular MCSD. So these are a little bit lower priority. They don't need mechanical support if they have an arrhythmia. So it's similar to status 1, but a little bit less critical. And then we get into status 3 and status 4. So these are dischargeable patients. These are patients that could go home. They might be on inotropes. Again, a little bit lower in priority. And again, status 4 even includes retransplant. So we move further down the priority. And then status 5 is on people who are on the wait list for at least one other organ at the same hospital, so a little bit different status. And status 6 would be any other active candidate. So they all meet the criteria, all have a need, but they're not, a higher priority due to, whatever their current medical condition is. That would be status 6. And some people break down status 1A to 1B in some facilities, but this is the stuff from OPTN. Okay, so again, you can see all the different check marks, right? These are patients status 1, the highest priority. These guys are on like cardiogenic shock, cannot leave the hospital. Then you get into status 3 and status 4. These are patients that could possibly go home, right? They may they may be able to go home, or they may be on inotropes without monitoring, stuff like that. And then status 6 would be anyone who's eligible, but not the higher priority, right? So looking at again these criteria. Now there's some decisions here and how we kind of decide how patients going to get evaluated for a transplant. So they have they get referred to a heart failure center. If they are in a compensated heart failure, we make sure that we, getting medically managed. It's still not, improving, then we assess some limitations, put them through a stress test. If they're stable, just follow it clinically. If we, after that further assessment, right heart cath, stress test, we notice a reduced cardiac index. Some people say, I think like 2.1. If we see that, maximal oxygen consumption, again, below 12 if they're on beta blockers, or below 14 if they're not on beta blockers. And then they're frequently in and out of the hospital due to decompensation, right? They're currently compensated, but they decompensate all the time. And then all right, we're gonna work them up for a heart transplant, okay? And then, or someone comes who has heart failure, is acutely decompensated. We try diuresis, they're not really effective. Then, okay, if like their heart failure is decompensated, it's not getting better, we try to move fluid off of them, then it's continuing to worsen, their kidneys continue to further fail. Again, we mentioned when your heart fails, we're not perfusing the kidneys as well, and the kidneys begin to fail. So, so an acute decompensation does not respond, then we're going to work them up for a transplant. So it can be different scenarios, the same outcome. Now, in terms of the procedure, the patient's going to have a median sternotomy. Again, like we mentioned, they're going to crack open that sternum at the middle, and we're going to reflect open or open up and retract open the chest wall to expose the heart. We're going to cut out the heart and then replace it with the replacement organ. This is an example here of a Ex-Vivo heart perfusion device. So this helps keep a heart preserved while we are preparing it for transplant. So it's harvested from a patient, put in this device, kept perfused, and then we take it to wherever it's going to be transplanted. This is just a breakdown at the number of length of stay for patients after heart transplant. So again, these patients usually in the hospital a little bit longer. In my experience, we typically see patients in the hospital for about 2 to 3 weeks. On the rare end, if they're sicker, if they have complications, they may be there a little bit longer, about 20% of cases. But typically, patients are going home after about 2 to 3 weeks in the hospital, right? And again, just looking at comparisons in Europe versus North America. Europe, patients may stay a little bit longer. Maybe there's differences in their healthcare, resources, or how it's billed through insurance. But typically in the United States, you're going home generally, within a couple 2 to 3 weeks, at 4 weeks at most, right? So just because we want to be monitoring them as close as possible, especially looking at the biopsy. So as soon as someone has a heart transplant, even if they go home or discharged, or usually staying at a hospital-appointed housing. So they're there, maybe a block away or right next door to the hospital, so they can kind of get in and out. But so they're discharged, not actually in the facility, but they're at a hospital-approved facility. That's kind of what we had in the VA system. that because they go in for monitoring every week. So they'll send a little guide wire down, a catheter down, do a little biopsy of the heart, making sure that no acute rejection is being observed. So this is done weekly for the first 4 weeks, and every 2 weeks after the following 6 weeks. And usually they're still in that kind of that hospital appointed housing, and then monthly for the next 3 to 4 months, and then every 3 months until the end of the following year. Again, that first year is really the big landmark for a lot of facilities, and then 3 to 4 times the following second year, so quarterly, and then after the second year, we're looking at maybe once or twice per year, because again, we're not really concerned about rejection after that first year, especially after the second year. And then we grade things in terms of the biopsy, in terms of what kind of rejection we see. Is it mild, moderate, or severe rejection, looking at some of the changes into the myocytes of the heart. So in terms of adult transplant rehospitalizations, this just shows you the percentage of individuals who do not need rehospitalization or do, right? So as you can see, like, we've gotten a lot better at keeping people out of the out of the hospital, right? So within the first year, 60%, right, don't require hospitalization, and then after that second and third year, again, because projections kind of like gone by the wayside still to a degree. We're still doing pretty well. The bulk of people don't get readmitted, and the leading one would be maybe another condition, like not injection, not infection, and then within the first year we still see infection as a pretty significant reason for why people get readmitted, right? So again, we do a pretty good job of keeping people from having to be readmitted, but there are still even within, even after 2 to 3 years, there's still roughly about 35% or so, or 30% of people who do get readmitted, and it's quite often, maybe not even something related to the infection, could be another complication related to the transplant, though. And again, looking at overall survival rates. So, this is a plot looking at the Kaplan-Meier curve, which gives us survival plotted over time. So in 1982 to 1981, right, kind of the dawn of the heart transplant era, the median survival, or years after transplant, the median, so 50% got to this, or halfway point, is 8.6 years. That's gone up every generation. So now we're in this novel one. We're still trying to figure that out, but the plot looks better, right? It shifts up every single year. It shifts to the left. So 2012 to 2008, we're looking at the median survival rate. So we get the 50% at 12.4, right? So if we plot that again here, the 50%, to survive, roughly about 12.4. And if this follows suit, it's going to be even a little bit higher, right? So we're getting better and better at keeping people alive. And a lot of that has to do with improvements to, immunosuppressants, LVAD therapies. We're also able to keep people, we talked about LVADs, we're able to exercise people so people are even a little bit more fit sometimes, maybe prior to transplant, like the muscles are a little bit better. They do a little bit better after transplant. The pre-transplant rehab is really starting to become a little bit more better supported. So again, right now we're looking at roughly 12 years for at least 50% of individuals. Or better yet, at 12 and a half years, 50% of people will survive. And then we're looking at, again, survival curves for retransplant. It's going to be a little bit lower for retransplant. Again, it's going to shift down a little bit because it's just a little bit more medically complex. But primary survival, if we factor in everything, we're looking at 10.9, retransplants included in this 6.6. So this is any transplant, and this if we extract this out, looking at retransplant, it's a little bit lower, right? So that's any type of transplant, and then it's because the retransplant rate's a little bit lower. And again, just looking at the causes of death right? Or it gives an indication of the significant complications that may arise, right? So the leading one being in that first 30 days is graft failure. We talked about that hyperacute rejection, right? So that's like the graft just does not take. It doesn't get vascularized. And then we see multi-organ failure as well as infection. And as we move to that 30-day window, infection becomes kind of the king concern. And then, as we get further and further out, we're looking at malignancies, right? Especially after that, 3 to 5 year period that is chronically immunosuppressed. Okay. And I like this plot here. It just shows us again, like that first 30 days. Again, this is plotted over, over the history, from 94 to 2017. But looking again at graft failure being the leading cause within that first 30 days, and then infections really spiking after that 30 days of being, again, you're on those chronic immunosuppressants. And after 30 days, that graft failure starts to kind of dip down, while malignancies start to kind of creep up, right? Again, related to that chronic immunosuppression. And infections, again, start to ramp back down as we start to titrate people off of immunosuppressants. And looking again, this is more recent data, not factoring in every single, every year, but just more recent data from the past decade. Again, looking at graft failure, still a concern in uncertain populations, but again, we can see how other concerns, other complications arise over time. And this is more incidence versus death. So this is death. This is the number of individuals who the incidence of the causes of death as well. And then looking at the severe renal dysfunction, again, we've gotten better at this because the drugs are a little bit better than we have now. Again, if we look at the Kaplan-Meier curves, we've shifted this up as well. So, now where people would be at, and we're looking at freedom from severe renal dysfunction. So, at in our early up to 2003, at 5 years after transplant, only 75% were at free from significant renal issues. Whereas now, more recent data, we're looking at year 9, it's almost doubled it, right? So people are doing a lot better with their kidney function after transplantation. This is only in a 10-year span, roughly, difference. So another concern that we're also seeing after transplant, which is kind of unique, is this we call cardiac allograft vasculopathy, which basically we see this calcification of the vasculature. We think that may be due to some of the immune changes that happen after cardiac transplantation. But as we can see here, we've gotten a little bit better at that as well. Again, that curve has shifted up a little bit, so more people don't have this, right? So this is, again, freedom from CAV, and again, the higher this number is, the better off people are. And again, looking at malignancies, again, similar to CAV, we've gotten better at it. We've shifted this, out a couple years, the 75% marker. And if things kind of trend the way we are expecting them to, it's still gonna, we're still gonna do pretty much better, even at the 50% mark of freedom from malignancy. And again, this is related to the immunosuppression. Again, the longer you're on it, the higher generally your likelihood of developing a malignancy is gonna occur. And then looking at any rejection. So again, we've gotten much better at it, right? So there's a percent of individuals experiencing any sort of rejection. 2004, 30% within the first year, roughly. And now we're at maybe 25%. So we cut that down by 5%. A lot of that has to do with our improvements in these medications. So this is just great to hear and see. And then looking at freedom from hospitalizations for rejection by ERA. Again, this is freedom, right, from rejection. So we have gotten much better medications. So, we're looking at 50%, right, was at 2.5 years, right? We're only 50%, right? We're free from this, meaning that we're at that halfway point. With our recent advances in medicine, that we haven't even, where we would be at 2.5 years, we haven't even crossed that threshold yet. So again, our treatment options for these patients are better, and we're seeing more and more people not experiencing these rejections because our medications are better, right? We're hovering around, 60% or so, right? Even up to about 3 or 4 years, not experiencing any sort of rejection. And that explains kind of why we see this figure here, right? We've cut into that about 5% for experiencing any rejection within the first year. And then we look at what do we see plotted over time. It's gotten better and better. So that was heart transplant. The next unit we'll get into lung transplant and some of the unique things that occur with that procedure.